Any comments? Well, I think that as we look at this, I think that it seems like it's a safe procedure and something that's going to occur, but that we can proceed, and people just need to know that these potential operations are going to come about. But we appreciate you showing this data and the safety of this. But again, it brings out the whole issue of ventral hernia repair as having many associated operations with it, not just the repair itself. Any other thoughts? All right, thank you.
Thank you.
Final paper of the session is going to be hospital costs associated with patient comorbid risks, operative variabilities, and postoperative complications in ventral hernia repair. A ventral hernia repair hospital cost primer. Margaret Plymale and others from Kentucky will be presenting.
Good morning. Thank you so much for the opportunity to present this work today. Our topic is the cost of comorbidities and complications to hospitals associated with ventral hernia repair. Here's our disclosures. Federal and private payers are targeting increased value through both reduced cost and improved outcomes. A previous cost analysis from our institution showed that the majority of cases of ventral incisional hernia repair were performed at a financial loss. And because of the change in payment strategies, it's become more important to understand the economic impact of ventral hernia repair. However, clinically relevant data is scarce. We hypothesize that patient comorbidities, operative factors, and postoperative complications are the drivers of increased cost for ventral and incisional hernia repair. We pulled cases from our local NSQIP database for a 3.5-year period of time, and we combined that data with our hospital cost data pulled from the hospital accounting system, which included direct and indirect costs. We divided the cost data into 3 cost groups: operating room, service and supply costs, total hospital encounter costs, so the operating room costs were part of the total hospital encounter costs, and the third cost group was 90-day post-discharge hospital costs. We compared costs using non-parametric tests, and we also used backward stepwise regression to assess the independent contribution to cost of the pre-op, peri-op, and post-operative factors. There were a total of 385 cases in our data set. The average age of the patient was 51 years, and 59% of the patients were female. Laparoscopic and operative repairs were nearly equally divided in the data set, and a little over 2/3 of the patients required an inpatient admission. We report costs in median and interquartile range. So for all cases combined, the median OR costs were $6,900. The median total encounter costs were $10,700, and the median 90-day post-discharge costs were $0. This figure allows us to look at total hospital encounter costs across CPT code. The green are the open repairs, the blue are the laparoscopic repairs. The median is presented by the dark line in the colored rectangles, with the first and third quartile represented below and above the median, and the whiskers represent the boundary for outliers. So first we looked at the preoperative risk factors, and each of these factors was associated with increased costs in one or more cost group. So as you can see, ASA Class 3 was associated with increased costs across all 3 cost groups, whereas presence of a preoperative open wound was associated with tripled costs for OR costs and total encounter costs, but no increase in the 90-day post-discharge costs. As would be expected, many operating room variables were associated with increased costs, and these included mesh type and size, open versus laparoscopic repair, longer duration of operation, and recurrent versus initial hernia repair. But as shown here, any wound class greater than 1 was associated with increased costs across all 3 cost groups. Here we separated the laparoscopic and open repairs and compared costs for patients whose BMI was less than 30 versus those whose BMI was greater than 30, and showed that for the open repairs, there were increased costs for patients whose BMI was greater than 30. The third main factor we looked at were postoperative complications. We looked at wound complications, sepsis, septic shock, urinary tract infection, venous thromboembolism, and others, and found dramatically increased costs for all complications. And here in this table shows the wound complications, and as you can see, for a patient that experienced an inpatient surgical site infection, the total encounter costs tripled. And for the patient who experienced post-discharge superficial surgical site infection, the median 90-day costs rose to $5,600. Here we look at just the 90-day post-discharge costs for open repairs. On the left, we compare costs for patients who had no surgical site infection compared to those with superficial surgical site infection or deep or organ space surgical site infection. And on the right are the 90-day costs for patients who experienced a wound dehiscence versus those whose surgical wound remained intact. Also, when we looked at the 90-day costs, we found that for 42 patients who went to the emergency room but were not readmitted, there was an increase in the 90-day cost to a median of $2,600, and for the 64 patients who were readmitted, there was an increase in the 90-day post-discharge cost to $7,700. And in our multivariate analysis, we really found no new information, as all the predictors of costs from the univariate analysis also were independent predictors of increased costs. So in summary, there are multiple strategies recommended to reduce costs, especially optimization of modifiable risk factors and quality improvement efforts such as enhanced recovery programs specifically designed for ventral hernia repair. Also, as someone who facilitates the care of these patients, I think it would be important to provide surgeons with data not only of the morbidity statistics, but also information about the case mix, the comorbidities, the quality improvement efforts that were part of the patient care, cost data, and patient satisfaction data, all in one presentation in order to allow the surgeon to improve their practice. The main study limitation was underestimation of 90-day post-discharge costs, as any care that was provided outside of our facility was not included in the 90-day costs. So in conclusion, this study provides a unique insight into clinically relevant drivers of cost, and a hernia care bundle payment model is needed that would incorporate risk adjustment, complexity of repair, and postoperative outcomes in order to allow surgeons and hospitals to care for these patients without incurring a financial loss. So thank you very much.